Hello, hello.
Good morning, distinguished guest, respected Director Madam, esteemed colleagues, and dear students. On behalf of CSIR-CDRI, I extend a very warm welcome to the Transnational Research Series 2026. And what makes today even more special is that this lecture is a part of Women's Day month celebration. Because today is not just about research, it's about impact, it's about voices, and it is about the power of science to change lives. When women are empowered with knowledge, opportunity, and leadership, they don't just break barriers, they build new paths for the society. To begin this wonderful session, may I invite our esteemed director, Dr. Radha Rangarajan, and our distinguished speaker, Dr. Prabha Chandra, to kindly take their seats on the dais. I also invite Dr. Vivek Bhosle, chairperson of the Translational Research Series, to please join them. To begin this wonderful session, may I now invite our director, Dr. Radha Rangarajan, to please set the tone for today's session. I invite our respected madam to deliver her opening remarks.
Thank you, Vinita. Good morning, everyone, and welcome to today's lecture by Dr. Prabha Chandra, Senior Professor of Psychiatry and Director in Charge at NIMHANS. Dr. Chandra, thank you so much for accepting our invitation to be here. This is the first lecture of the Translational Research Lecture Series for 2026. As you all know, this is a quarterly series in which we invite clinician researchers to CDRI, and the intent is to build closer connections with the clinician community and sharpen our own focus on problems that require research-driven solutions. As Vinita said, there's another reason we've gathered here today. International Women's Day, of course, is celebrated on the 8th of March. It is customary to mark the day with a variety of events. At CDRI, we do a month-long program with multiple events throughout the 4 weeks, highlighting various aspects of women's participation in the workforce, society, and family. Dr. Chandra's lecture today has special importance for all of us. According to a Nature report published in 2024, only 5% of global research and development funding was allocated to women's health research. This was split into 4% for women's cancers and 1% for all other women's health specific health conditions, with 25% of that further limited to fertility research. It is no surprise then that there are fewer interventions, drugs, and solutions that specifically address women's health issues. Dr. Chandra's work tries to correct this imbalance by putting the focus on women's health, mental health in particular. She will talk to us today about perinatal stress. This refers to the emotional and psychological strain experienced during pregnancy and during the postpartum period. This has many implications for the health of the mother and the child, but not enough is known. Dr. Chandra is a pioneer in the field and has helped set up the perinatal psychiatry service and mother-baby inpatient psychiatry unit in NIMHANS. And we really look forward to your talk today. I want to thank the organizers of today's event. The Translational Research Series Committee is headed by Dr. Vivek Bhosle and Dr. Kumar Velu, Dr. Ravi Bhatta, and Dr. Vinita Rai are members. Thank you so much for the efforts that you've put in. I also want to thank Dr. Shubha Shukla, who heads the Women's Month Organizing Committee, and Dr. Sanjeev Yadav for all the outreach activities. Once again, welcome to this program. And students, I request you to put a WhatsApp message in your group telling your friends to come ASAP, and they will get, they are in for a treat. So please tell your friends to come quickly. We're almost at the starting point of the lecture. Thanks to all of you who are present here today. Thank you.
We are deeply honored to have with us Dr. Prabha Chandra, Director and Senior Professor of Psychiatry at NIMHANS, Bangalore. But beyond titles and achievements, Dr. Chandra represents something more powerful: science with empathy. She is a pioneer of perinatal psychiatry in India, and she has established one of the country's first mother baby unit, a space where care does not separate a mother from her child but strengthens that bond. Think about for this for a moment. This is not just clinical innovation. This is compassion built into healthcare system. Her work spans perinatal mental health, gender-based violence, and women's psychological well-being, areas where science directly meet human vulnerabilities. With over 350 publications and her leadership as editor in chief of Archives of Women's Mental Health, she has shaped global conversations in this field. But what truly stands out is this: her work does not stop at discovery, it reaches the people. And that is the essence of translational research, when science moves beyond the lab and makes hope for someone's life. With this, I would like to invite Dr. Prabha Chandra to deliver her talk.
Good afternoon, everybody. Thank you very much, Dr. Radha Rangarajan, for inviting me. I'm really delighted to be here. Dr. Vivek Bhosle for approaching me in the beginning and convincing me to come. This is a very transitional time for my institution, and but I'm really delighted to be here amongst all of you. One, because of course, this is part of Women's Day celebrations, and as you just heard, my work in all these 40 years of my academics has been in the area of women's health and women's mental health, which, like your director mentioned, is a very neglected area, and especially in science funding. And more than anything, I think as clinicians, it's very important for us to also understand how we can take what happens in the lab into the community, into policy, and how do you make that connect? Because I think many of us work within laboratories and sometimes are not able to see the end result. And I think one of the things that we need to do is to have these collaborations to ensure that the woman or the young child reaps the benefit of all the funding that has gone in, all the human hours that have gone into the lab, and reached certain discoveries, conclusions. So, as I was saying, I think for me, women's mental health or women's health has been a priority. Uh, I think, like was mentioned, the one of the things is that, of course, there is less funding, but also that in addition to funding, the amount of sex and gender aggregated data is very, very less. So even in animals, as you all know, unless it's a study which is looking at reproductive health, the animal models which are chosen are invariably male, because otherwise there will be complexities. But as a result, what happens, you can imagine that we use a lot of data from male rats onto women, and it's very, very important for us to recognize this. In fact, the Guild of Editors has now introduced something called the SAGER guidelines. Some of you may have heard about it. The SAGER guidelines is basically sex and gender aggregated research. So in every study, you have to actually now mention about, have you taken women or not in these studies? Or if you're doing an animal model paper, then you have to mention whether the animal models included female rats or female whichever animal. And if for some reason it was not included, then what was the reason why it was not included? So I think more and more people are realizing why it is important. To just give you a small example, when I'm in a place where we are talking about drug research. So there is a medicine called zolpidem, which is a sleeping pill, and it was never tested in women, either in animal models or in humans. And in America, the same dose was given to both women and men. And there were, so 10 mg is the starting dose for men, and all women also got 10 mg of zolpidem for sleep. And what happened was that there were several road traffic accidents. because the metabolism of zolpidem was very different in women compared to men. And there was a huge hue and cry, there was a case. And that is when one realized that you just cannot extrapolate data from men onto women. And now you have a blue zolpidem and a pink zolpidem, just to make sure that there is no confusion and that people are, women are taking the right dose. So this is just a small example of how, women's health research needs to advance a lot. There are so many conditions which cause a lot of morbidity. For example, endometriosis is one condition which is so common in young women. A lot of young women have painful periods, excessive bleeding, but it's a condition which still has not been researched adequately. In fact, there's hardly any funding for this. Um, Whereas, cardiac conditions or strokes, which are much more in men, actually got a lot of funding. And like your director mentioned, the only funding which we have got in women's health is basically for cancers. And that too, specific cancers like breast cancer or cervical cancer. So I think we have a long, long way to go in terms of, very gender focused research. And I'm hoping that an institution like yours will actually do an audit and see how much of the research is relevant to women, and how much is common to everybody, including in all the work that we do with animals. Having said that, I'm going to talk to you about something very different. As you heard, perinatal mental health is my area of interest, which basically perinatal means pregnancy until 1 year after childbirth. So we call this the perinatal period. In fact, some people are now saying 2 years after childbirth. So we basically use the term 1001 days of a child's life and a mother's life. So the 1001 days includes 9 months in the womb and then 2 years later. So we are looking at 1001 days. And why are these 1001 days very, very important? These are called the critical 1001 days because in the womb for 9 months and outside for 2 years is the time that the maximum brain development is happening in babies. All the things that they're achieving in these first 3 years. So if you have to give input, give it in these 3 years. And remember, that includes the mother's pregnancy. A lot of behavioral issues can be managed if adequate care is given to babies in this age group, including soothing, managing emotions, and a mother has a very, very important role to play in this particular period. A mother or a mother substitute, but somebody who's mothering the baby. So this is a new area because if you ask about perinatal mental health, most people will talk about postpartum depression. Everybody more or less knows something about postpartum depression that happens after a woman gives childbirth. But sometime in the late 90s, a new field came up, which was basically looking at what is the impact of a mother's mental health on the baby which is growing in her womb. What is there any impact? What is going to happen? Should we do something about it? And that is what I'm going to talk about. I'll take you through the journey of how we started looking at this area, and then the work that is happening globally, and then a little bit about what is happening at NIMHANS, where I come from. So this is greetings from NIMHANS. Right now we are in the full spring bloom. Anybody who's been to Bangalore knows that Bangalore becomes completely pink during this period. And you have a lovely campus. I think NIMHANS has equally good campus. The advantage is that we have very old buildings, so they are really beautiful and very nice. And I must say that I was telling some of the faculty here earlier that many of my colleagues are very excited about possible collaborations with your institutions, and I hope that our partnership is going to grow. So let's start with this particular slide. So what happened was that in the early 2020, sort of mid 2020s, there was this big article in Time magazine about how the first 9 months of your life change the rest of your life. Yeah. So the first 9 months that you are in your mother's womb actually determines many, many, many things downstream. And why do early life experiences leave biological footprints that last decades? And I think this is a question that we have been all working with in the last 10 years or so. In fact, one is in the womb, but even in the very early childhood, like I mentioned, we call them adverse childhood life experiences. And these adverse childhood life experiences seem to determine many things: diabetes, hypertension, alcohol dependence, schizophrenia, depression, suicide. So, a large number of things which are happening in these first few years of people's lives actually determine what downstream effects will happen. And we have tried to find out what could the pathways be of this. So, when this happened, when these articles came up, um, we were grappling with this. We were seeing it happening. We know when in psychiatry, when we take a good history, we always ask, how was your mother's health when she was pregnant? It's a question that traditionally we have asked. And we started questioning, why did we ask this question? I mean, of course, there's preterm labor and there's viral infections, all of that can cause problems. But what else are we really asking? Were you a wanted child? Was there violence in your mother's life? So we asked these questions, basically trying to understand when the brain was developing in the uterus, in a mother's womb, what was really going on in the environment. So we must remember that the womb or the uterus is not just a biological entity, it also has a social environment, it has a psychological environment. So now, more and more, the uterus, when the baby is in, is being considered as not just a biological holding, but also a social holding and a psychological holding. So at this point, I had the opportunity, when these articles were coming up, uh, we were running a cohort study where we were just looking at something very simple. The same thought was coming to our mind because we were seeing things in the field. And so we got a ICMR funding, very small funding, where we were looking at about 800 mothers and trying to follow them through pregnancy, looking at anxiety and depression. And our aim was to see whether mothers who had anxiety, depression, or excessive stress have low birth weight infants or preterm infants. That was a very, very simple question that we had. So, is there something which is going on which makes these women have babies who are low birth weight? And how much is it dependent? So, as you can imagine, if a mother is very anxious or depressed, she may not go to antenatal care properly. She may not take her iron and folic acid nutrition properly, right? So, it could be that the low birth weight was because of those reasons and not just because of stress. That was what we were trying to understand. And as we were doing this, as we were collecting data, and this was in a particular area in Bangalore, where we would go to the antenatal clinics, we would recruit mothers. We will assess them in great detail for anxiety, for depression, for any violence they were facing, for stress. And these were all first time mothers that we saw, and tried to then follow them up. And you can imagine a study like this is quite hard, because in India, what happens is that a lot of mothers will go off to their mother's place to have the baby. So we have to actually follow them up, make sure that we weigh the baby, make sure that we get the term of the baby. So it was quite an intensive project, and it ran over 2 years. So while we were in the middle of this project, I had the opportunity to go to the University of Liverpool on a visiting professor grant. And what I found was that while we were thinking about this here in India, in Bangalore, in Liverpool, and I had no idea about this, in Liverpool, there was a similar group which was looking at the same thing. But what they had done was they had started that study 5 years earlier. So their children were now 3 years old. So not only were they looking at birth weight and gestational age, they were also looking at child's behavior, child's development. So, if a mother had a problem in pregnancy and the immediate postpartum period, what was the outcome in the children later was something that they were studying. So, this got us really excited. And I said, I'm just starting my study. So, this is a wonderful opportunity for us to do something very similar. So, now we have a parallel cohort in Bangalore and another cohort in Liverpool, where we are using the same measures in the group of mothers and children and trying to compare, is it same, is it different, what is really happening, and I'll show you some of those findings. So this is how this research started sometime in 2014. So it's been about 12 years of working with this area very intensively. So this is somebody who is a very famous person. His name is Philip Barker, and he developed this. He brought out this new science. It's a new science. It was not there earlier, which is called the developmental origins of health and disease. It's called DOHAD. It's a huge area of research. Some of the people you might have heard of in India who are working in this area is Dr. Yagnik in Pune, who works in diabetes basically. So what Philip Barker had nothing to do with mental health. What he found was he was a very good epidemiologist. In fact, he got something called the Richard Doll Prize, which is the equivalent of a Nobel Prize for epidemiologists. So he was a very astute scientist. And what he found was that a lot of people were developing diabetes and hypertension at age 40, and some of them were not. And he tried to see whether he can get the records and see what was happening in their prenatal period. So NHS, fortunately, in the UK, has these longitudinal records. So he just went to the records and said, let me see what happened. Why did these people develop diabetes and hypertension? And what he found was, and that kind of revolutionized care of mothers, because he found that nutrition, maternal nutrition, was what was causing this problem, poor maternal nutrition. So let's say a mother does not get adequate nutrition when she's pregnant. The fetus tries to conserve as much nutrition as possible, wants to adapt itself in such a way that I have to make sure that I get adequate nutrition. So the metabolism changes. But after the baby is born, if there is enough food, then what happens is that the baby is still thinking, the fetus had thought that I don't have enough food. Now later the child gets enough food, but the brain and the system still thinks there is no food. And that is one reason why obesity, metabolic syndrome, hypertension happens. So he kind of gave this hypothesis which said that if you manage nutrition in a mother's life, then you're actually going to prevent a lot of downstream effects that are happening. And this is very relevant for India and countries where there were famines earlier. So when there were a lot of famines, what happened is we got conditioned. Our forefathers, our foremothers, whoever their great great grandmothers, they got conditioned in such a way that because there were huge famines in India, so the fetuses actually started conserving this nutrition. And but when they came out, there was enough and plenty, and that is why now we are seeing the effect of that. What happened, which we call the thrifty fetus hypothesis, which is still very much a reason why there's so much diabetes and hypertension and metabolic syndrome in our country right now, because we're still thinking that it's thrifty, there is no food, but actually there's a lot of food and there's very less physical activity. So then what happened? So this happened for nutrition and diabetes and hypertension. Then people started finding in many, many studies that when you have prenatal mental health problems, when a mother is facing violence, when a mother is facing a lot of stress, then the kids are actually going on to have behavioral problems later, right? So there were some very long studies. One of them is called the ALSPAC study, which is done in the UK. It's called the Avon longitudinal study, and they follow up lots of young people through, from babyhood, from pregnancy till later. And they actually found very interestingly that mothers who had depression or anxiety, children at 3 years, 5 years, 10 years, higher rates of ADHD, higher rates of learning problems, higher rates of anxiety. So trying to see what is going on. And this gave rise to a field called fetal programming. So the idea of fetal programming is that the environment in the uterus during different critical periods. So you may have the first 3 months, the next 3 months, the next 3 months. During different critical periods, develops susceptibility to specific conditions. And that is the reason why and it alters the development of the fetus. So so you can imagine that the way the mother is feeling actually gets transmitted to the fetus, to say it very, 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 you know, people in fact say that, oh, it was told in Mahabharata that, Abhimanyu heard the whole Chakravyuh when he was in the womb. Yeah, I mean, there is some, who knows, but this is fetal programming, that a mother's mental, but then how does it happen? It's not because the mother's telling the fetus that she's upset. What is the science behind it? And that is what people had started exploring. This, like I said, this science is not very old, so it's only about 15 years old. People had started exploring, what is it, what is, if a mother is depressed or anxious or is facing violence, what is it that happens to the fetus, that the fetus develops problems later. So this was called fetal programming. So this is my wonderful staff. As you can see, it's a big research group. I have about 40 people working with me, my clinical team, my research team, all of them very young, very enthusiastic. We have about 15 PhD students in this group, and this is just one group in NIMHANS, which is working on this area. And these are my other collaborators and funders. We've got funding from various organizations, including, all the ones which have been linked here. So what I'm going to talk today a little bit more based on this background that I have told you is talking to you a little bit first, what is prenatal stress, various types of prenatal and postnatal stress. I'll talk a little bit about downstream effect on pregnancy, infant and the child. And then I will move on to what we call the Bangalore Child Health and Development Study, which is the study which we're talking about, which is in its 12th year now. So our babies, so we saw these babies when they were in the mother's womb. And now they're all 11 years old almost. Many of them are 11 years old. So it's a great opportunity to actually see these, the newborn, then the 1-year-old, and the 2-year-old, and the 5-year-old, and the 7, and now the 9 to 10-year-olds. To actually being able to characterize these people, in a very, very deep manner. We have a lab in our community where mothers and babies and children come, and we do, and I will show you what we do with them. So just to give you some idea about what is stress. So we all keep saying, no, stress nahi lena, stress nahi lena. So what is stress? So I think we must remember that basically when we are confronted with an external threat, okay, the two questions we ask is, does the event constitute a threat? And do I have the resources to handle it? So how threatening is the condition? And do I have the internal resources to handle it? If I do not have so it can be, so there's what is called the primary appraisal. It can be positive, it can be dangerous, or it can be irrelevant. So some stresses I'm not bothered about. Some stresses are positive stresses, gives me hope, makes me do things, or it may be dangerous. Then I decide, if it's dangerous, then do I have the resources to handle it, or do I not have the resources to handle it? The moment I do not have the resources to handle it, how do I overcome this stress? So just think that there's a stress that, there's a big loss, financial loss. Now, I can take it as a positive stress, thinking that there is a financial loss, but I can work harder, I can get a new job. So that can be considered a positive stress. But if I feel that no, this is going to really damage my life, I'm not going to be able to do anything, then I'll start thinking, what are the resources? Where can I get a loan? Who can I talk to? And if I have resources, then it does not become that stressful. It's a positive stress. But if I do not have resources, then I use different types of coping. One is a problem focused coping, that I don't have money. What are the ways in which I can manage? Or you can have an emotion focused coping, where I say, I'm devastated, I'm gone, I cannot live further. What is this? This is terrible. So when it becomes more emotion focused coping, that is when what happens, our brain starts acting. So when there is a lot of stress in our brain, we have something called the hypothalamo pituitary axis. So whenever one is stressed out, you have a loop which forms in the brain and the body, which increases a whole lot of what is called cortisol. Many of you know about cortisol. It gets increased, and it causes effects on the body. Most often it is useful because it helps us do things, but sometimes what happens is if the cortisol is excessive, then it acts negatively in the body. And that is why when chronic stress is there, or I'm overwhelmed with stress, then you might have heard that the person who's very stressed developed a cardiac event. When a person was very stressed, the person developed diabetes. So you can have all these things because of stress, because it acts on it's not just mental. When you say stress nahi lena, it's not just mental, it's every stress that you are taking excessively is acting on your body and through the hypothalamus pituitary axis, which is very important for all organ functions. Now that we know what is stress, let's look at what are the different types of prenatal stress, and all of these we studied. So life events. So when you're pregnant, when a woman is pregnant, the woman can have lots of life events. There can be a loss of job, there can be death of somebody close to them, there can be a change of house, there can be a loss of the child. So many life events can happen. Migration can happen, a disaster can happen, COVID can happen. So all these are life events which can happen. Now, the more severe the life events, the more problems in the HPA axis that I have said. So it's very important for us to remember these life events. So we measure life events. Let us say a woman has lost somebody very close to her when she is pregnant. It's a huge life event. There would have been very marked increase in cortisol. What impact would that have had on the fetus is something that we need to measure. Domestic violence, and I'm going to show you some data on domestic violence as a stress and its impact on the fetus. Big issue in our country. If you look at our National Family Health Survey data, rates are very high, and I will show you our rates. So women face domestic violence even when they are pregnant. What impact does that have on the fetus? Women can have pregnancy specific anxiety. So there's some women who will have anxiety specifically about the pregnancy. If this woman has had an abortion before, or if she's had a stillbirth before, or the family is pressurizing for a male child, all of these can cause what are called pregnancy specific anxiety. And sometimes it can be very high. Then, of course, there can be depression, suicide. I want to mention here that India is the place in the country in the world where maximum number of women suicides happen. So normally across the world, there is something called the gender paradox. What is the gender paradox? That more men die by suicide compared to women across the world. But India, Bangladesh, Pakistan, Afghanistan, 4 countries, South Asia, are the countries where the gender paradox, it's almost equal, the rates. And in some states, it is higher. Women have more suicide than men. And interestingly, the maximum number of suicides are happening in the reproductive age group, between the age of 18 to 35 in women. So India is actually, the rates of female suicide in the reproductive age group are the highest in the world. Okay. Pregnancy is not a time where women are protected. Our data, longitudinal data has shown that suicide rates are pretty high. Suicide attempts are high because of many social factors. So this can happen. And this suicidal behavior sometimes can happen independent of depression, may not be related to depression. Then I mentioned bereavement and post-traumatic stress disorders. Okay. The previous trauma that the woman has gone through, sexual abuse, other kinds of bullying, all of that can actually become more during pregnancy because it's a very vulnerable time for the woman. So these are the various types of prenatal stress that you have to measure. So you don't only measure depression, you measure a range of conditions which you see what is happening, how does it cause stress. So this was one very good real life example where the studies were done. So this was the 9/11, the Twin Towers, all of us know. And what scientists did is they took advantage of this situation and they actually looked at mothers who were pregnant during the time of 9/11 and how far were they from the Twin Towers. So people who were within 5 kilometers, people who were within 10 kilometers, people who were in another place, and they followed up these mothers and children to see what impact. So you can imagine if a woman was just 5 kilometers within the range of the 9/11, her cortisol must have just gone sky high when 9/11 happened, because the sense of vulnerability is so high. So what they interestingly found was that in these babies, and when they grew up to be children, they found low birth weight, they found preterm births, they found poor neurodevelopment. The nearer the person was to the 9/11, the more the problem. So pregnant women in the area in 9/11 actually had, and this was like a natural experiment. A lot of researchers now do similar natural experiments. For example, this was a huge ice storm which happened in the city of Quebec in Canada. So scientists took advantage of that natural disaster, followed up these mothers who had a lot of um, you know uh, stress, and found lower language abilities compared to children exposed to low or moderate levels of prenatal stress. So mothers who were very, very, so this was what happened was 5 days there was no electricity, there was no food, there was no water in this particular place. So they found that mothers who faced more stress, the children had more language problems, more neurodevelopment problems. So these natural experiments also give you a good uh, opportunity to study some of these very important things. So, how does maternal stress reach the fetus? Mothers feeling stressed, how is the fetus getting affected? This is one of the main hypotheses, and this is called the glucocorticoid hypothesis. So I mentioned to you that what happens is when a mother is getting very stressed, then her cortisol levels are increasing. Cortisol is a hormone which increases in the blood. Normally, the placenta has an enzyme which metabolizes the cortisol. So cortisol cannot reach the fetal brain, should not reach the fetal brain from the mother. But what happens is that and this is the enzyme which is there, the 11 beta HSD2 will metabolize all the cortisol. It will not allow cortisol to reach the fetal brain. But what happens is if the mother has a lot of, so when you see the yellow, the green is normal cortisol. When a mother is very, very stressed, like this disaster is happening, or she's facing domestic violence, or she's going through a lot of problems, what happens is that the cortisol increases much, much more. And this enzyme is not able to metabolize it. So the cortisol is reaching the brain directly. It is making changes in the fetal brain, and that is actually leading to low birth weight, metabolic dysfunction, and altered neurodevelopment. This is a fairly simplistic, but more and more data that this probably is causing, in many ways, this is causing the problem. So the placenta, there is, methylation is happening in placenta, and I'll show you some data from our lab on this, about how this happens. So this is like the gross hypothesis, if one wants to understand it. And this is very important, right? I mean, this is something that our policymakers need to know, that if a woman is going through stress, you're dealing with all these problems. So deal with the stress properly, handle the mother's mental health properly, so that you're not getting all these downstream effects in the child. However, as with everything else, the more you do research, the more you find other kind of pathways. So if you look here, there are multiple pathways now which has been identified. So for brain maturation, so of course there is the cortisol pathway, which is one of the main hypotheses. But then they've also found inflammation. So mothers who are going through stress also have higher levels of pro-inflammatory cytokines, and that may be also causing behavior and psychiatric disorders. There is an increase in what is called tryptophan. We all know that tryptophan is associated with serotonin metabolism. Serotonin is very, very closely linked to brain, and that can cause the problem. Then you have the reactive oxidative systems which are here, which are toxins. So that can cause problems and impair fetal growth. Catecholamines, that is, if a woman is very, very stressed, all of us know about the fight, flight, and freeze, right? So fight, flight, and freeze is that when you're faced with a threat, you will either fight, or you will run away, or you will freeze. And what happens in all these three situations is there is a high number of adrenaline, noradrenaline, the catecholamines increase. Now, what happens when catecholamines increase is the uterus has to get blood. Catecholamines are vasoconstrictors. They will constrict the blood vessels. So there is a problem in the uterine blood flow, and that can impact the baby. So when somebody hears a terrible news or something terrible is happening, if it persists for about 4 or 5 days, studies have shown that if you do an ultrasound and look at the placental blood flow, there seems to be a direct impact of the mother's mental health and the uterine blood flow. So that can cause, and of course, finally, the microbiome. We know that that is another major way in which the maternal microbiome can change because of stress, and that can also impact the fetal brain. So currently, uh, research is going on in all these areas, trying to understand how, because this is complex science, and to do this work requires clinical data, very very deep phenotyping, and it requires the lab to work very closely with the clinicians. So this work is going on, and every day newer results are coming. The other day I was reading an article which has actually done fetal brain imaging. So they've looked at mothers who were it's a Norwegian study where they looked at mothers who are very, very stressed out, have depression, and they have looked at the fetal brain. So they've done imaging in when the baby is in utero and try to look at the brain size as well as brain areas, and have found that women who have high stress levels, you can actually substantiate the same thing in brain imaging. So the more science develop, the more we get to know what could be these very, very important pathways. The other important thing is maternal circadian rhythms. So maternal sleep. So how a mother sleeps also affects the fetus. So if a mother is very stressed out, she's not going to sleep well, or she's going to be in bed all day and sleep more. Either of this can happen, and that can also lead to, so if you can see, maternal sleep disturbances can actually lead to deficit in fetal growth, adverse outcomes, circadian rhythms of the fetus, because the baby also understands when what is happening to the mom. The mother will all very often say that when I'm sleeping, the baby is quiet. When I get up, the baby realizes that mother has got up. So mother circadian rhythms are very intimately connected with the fetal circadian rhythms. So if a mother's rhythms are affected, the uh, fetus and the infant capacity to homeostatically adapt to the environment is also affected. So one of the things that happens when a baby is born, when a small baby is born, is some amount of soothing has happened in the uterus itself. The baby learns how to manage, the fetus learns how to manage difficult situations. Mom is not eating properly, mom is feeling stressed, so the baby learns. After the baby is born, the baby learns how to soothe itself. It's called self soothing. And how does it learn that? The mother or the grandmother or whoever is looking after the baby teaches the baby by carrying it when the baby is crying, by helping it soothe, by stroking it, by teaching the baby to regulate its emotions. And this regulation is very important. We have seen babies who do not have mothers, or whose mothers have mental illness, or mothers were absent, or children from adoptive families. These babies have lost out on those first few months of learning how to self soothe, to regulate yourself. So, what does it mean? So, it means is that if some problem happens, we are able to calm ourselves down. That is called self soothing. That is called emotional regulation. You are able to regulate. You're getting very angry, but then you tell yourself, no, I can't get so angry. I have to manage myself. Or you can say, no, I'm going to cut myself. Okay, so these are the two extremes of regulation. So emotional regulation is a very critical quality that babies start developing from when they are very, very young. And that is why we again emphasize that the first few years of a baby's life are extremely important for the children to learn how to manage their emotions. Because if you don't teach the babies then, just by doing soothing activities, these problems can get escalated later. Then, of course, I talked about the autonomic nervous system. Again, maternal stress can lead to, like I said, a whole range of uh, problems in the brain, which can then impact behavior. Okay, so we've talked about prenatal stress. Let's talk a little bit about postnatal stress. What happens after the baby is born? So a mother may have a poor birthing experience. A lot of mothers will tell you, I didn't want a cesarean section, but I had to get it. And I was very upset about it. Or that I was not told many things about my delivery, or that I was not treated properly, or that it was a very, very traumatic delivery. So a woman may have a very difficult birthing experience, which can cause postnatal problems. There can be stress for parenting. The mother may not be really capable of managing a baby. And so that can cause stress. Breastfeeding may be stressful. The baby may have poor infant health, like being in NICU or other things like that. Sleep deprivation, or one of the important reasons why a mother may get depressed is because she doesn't get sleep. And now we are doing more and more sleep education, particularly in women who've had prior mental health problems or prior depression, because lack of sleep seems to be a big trigger for depression. So we are actually encouraging that the couple should start discussing how they're going to manage sleep after the baby is born, because nobody discusses it. Everybody's bothered, bacha hona chahiye, the baby should be fine. But nobody really worries about what is going to happen later. Who's going to look after this baby at night? Can the mother get some rest? So I think sleep education is something which is very, very important. And finally, like I mentioned, domestic violence. So what happens is that you have the prenatal stress because of all the things we discussed. Then you have the postnatal environment where the mother may be depressed, but you also have environmental stuff happening. So the baby is dealing with a lot, the mother and baby. So you have pollution, you have crowding, you have nutrition, you have stimulation. Now, all of these things together act, and this part is now called maternal programming. So we had fetal programming. What it has been found is that the first few months of a baby's life, epigenetic changes can happen if the mother is not available or a caregiver is not available, and that is called maternal programming. So we are also looking now at what about the preconception stress. So it is now more and more people are saying that it's not enough to look after the mother when she's pregnant. It's important that you start looking after a girl much, much before. And that's where, if we are talking about International Women's Day, that is what we need to be discussing. That a woman who's going to be a potential mom, her mental health needs to be looked after right from the beginning, not just at the time that she's going to be a mother. And there are several protective factors. So it's not all bad. So even if a mother has been very stressed in the pregnancy, protective factors include social support, and it can actually make a difference. It is making the mother feel good about herself, maternal self efficacy. It is developing resilience in the mother. And also what we call maternal sensitivity, which I just discussed, that a baby needs to be taken care of when the baby is distressed, and baby needs to feel that the environment is safe, that I'm in a safe environment, that somebody will take care of me. That is very, very important for a baby, that somebody always be there to available for the baby. So just for the scientists in the audience, I just want to give you some idea about the various downstream effects. And these are all the articles which have come in the last 10 years or so. So if you look at different types of problems, so if you look at anxiety, the kind of methylation which is seen is very different in different parts of the gene. NR3C1 gene is one of the most important genes for mental health. The NR3C1 gene is one which manages our stress. And if there are methylation changes in the NR3C1 gene, that actually impacts stress regulation. So a lot of the downstream effect seems to be affecting the NR3C1 gene. Very interesting, in red, I have put about grandmothers' exposure to violence. So not only are we talking about mothers, we are also talking about something called transgenerational violence or transgenerational mental health that people are seeing, especially in places like Rwanda, where there was a lot of genocide and grandmothers faced a lot of problems. There were methylation changes which happened, which affected the mother, and that is now affecting the daughter. So they have 3 generations where they've actually shown how methylation has impacted the stress gene through generations. So when we are looking at women's mental health, we must remember that we're impacting generations if women are subjected to difficult situations. So natural disaster, the pathway is slightly different. So I think that is the reason why, like I mentioned, that the the field is complex. We have just touched the surface, but I think it's important as we go on to kind of, you know, type it carefully. What is the kind of stress the mother is facing? If it's grief, if it's bereavement, is the pathway very different? If it's depression, is the pathway different? How are all these things affecting? What is the role of intergenerational violence? Animal studies have been done. Those of you who work with animal models, there's some very interesting studies which have been done with rats, where what they have found is that when a mother rat has pups, they have actually introduced a male rat into the cage, and the male rat, is a little, aggressive towards the mother. The mother then stops licking and grooming the pups because she's so stressed because of the male rat. Now, what happens is that the male rat is then removed, but the mother still does not groom or lick the pups because she's losing that ability to be a sensitive mother. So the equivalent of carrying the baby and caressing the baby in rats is licking and grooming. And licking and grooming is very important for the pups, for synapses to be formed, for soothing to happen. Now, what happened was that when these pups, these female pups, had their own pups, these pups also did not look after their babies because the methylation changes had happened in them. So, we are talking about intergenerational trauma happening as an animal model, but now there are human models of intergenerational trauma happening. So this is what I called about maternal sensitivity and the importance of a caregiving environment. A sensitive mothering is extremely important. It is the ability of a mother to understand the infant's emotional state, that the baby is distressed, what does the baby want, rapidly responding to it. And I think this is something that actually sometimes needs to be taught because all mothers will not have it, on their own. And this is the difference we have in our culture, that if I compare the Liverpool cohort and the India cohort, the number of grandmothers and grandfathers who are there to look after the baby, even if the mother is depressed. So nearly 60% of our cohort had another caregiver to look after the baby. So you're actually, we are trying to see whether our babies are slightly better protected because there is somebody else. So all the more reason where, like they say, every baby needs a village. I think a baby and a mother both need a village to look after them. So to just summarize, different types of prenatal stress may have different outcomes, like we said. So some may lead to low birth weight, some may lead to low gestational age, some may lead to neurodevelopmental problems, some may lead to ADHD. Very, very early, high levels of stress have been found to be associated with autism and schizophrenia, first trimester. After that, it is more ADHD and neurodevelopmental conditions. And the very important thing is, like I said, the postnatal period may also have an influence and may be protective as well. And the stress in the preconception, and any analysis should be able to take, include all of these together. And that is where I think, so your mathematical modeling, etc., comes up, because these are very complex issues. You're not dealing with just A to B linear associations. It requires a very different way of analyzing the data, trying to understand what could be confounding, what could be protecting, what are the other factors which are acting. So before we sort of scientifically say that this is definitely there, I think it's very important for us to understand the complexities. So this is just a little bit about the Bangalore Child Health and Development Study that I talked about. So when I came back from Liverpool, we applied and we were very fortunate to get a ICMR big grant. And then we got a Medical Research Council UK grant. We combined the two and we were able to then run the study, a cohort study for nearly 10 years, 12 years now, which is no mean feat. It's a huge job to support mothers. So we followed them up pregnancy 3 times, then when the baby was 8 to 10 weeks, then 7 months, 12 months. The dip in 7 months is because we didn't get funding in time. and then 12 months, 2 years, and you can see how it continue. And we had, out of the 909 mothers, we had 820 live births, and we have been able to retain about 720 families. I say families now because they're all families now. And many mothers have had a second baby after that, or a third baby after that. So we have been able to follow up this group who is like with us. And now we are going to their school. So earlier we were looking at their development through the mothers and the grandmothers. Now we are able to do school assessment. So we are able to talk to the teachers to ask about behavioral problems in studies. So we're getting an objective assessment of that. And this, I think this kind of data is extremely valuable. This is probably the only study in India, longitudinal study, which has such deep data available from the time of pregnancy till the child is 10 years old. And now we are very excited and we are looking for funding, because now is the time they will all become adolescents. And we know that after the first 2 years of a child's life, where all the major synaptic changes are happening, adolescence is another time where all the synaptic pruning is happening. Brain is becoming very focused, very intelligent. And so what happens at this time? How does prenatal stress impact what is happening in adolescence? And I think this is a very exciting phase for us to see what will happen going forward. Like, which are the big kids who will develop problems? Which are the kids who will do well? What are the protective factors? Because adolescence is a time where a lot of mental health problems also start. So this is a time that we will be able to make out what is going on, and we are actually still exploring funding because these studies are quite expensive. So these are the various things that we have done in the cohort. We have looked at different types of mental health parameters. We have taken saliva from the mothers in the third trimester. We have taken saliva for immunoassays and DNA studies from the children at 6 months, 1 year, 2 year, and 5 years. And it's a big challenge because these little kids will come in the morning. So they come to the lab. They're not supposed to brush. And the children are very happy that they're not supposed to brush. They will all come, and we will have to then take saliva. And it's not easy sometimes. The mouth is dry. So we will have to tell them about different type of chart that they can have, different pastries they can have. And we know our staff is very adept at it making. So they will have to then salivate. We take the swab immediately, because this lab is in the community, because the community sample will never come to a hospital. So this is in the community. We'll immediately freeze it in the ice pack, take it to the lab. So it involves a lot of coordination, and the DNA will be extracted and kept. And then we'll give a packet of toothbrush and toothpaste to the child. And then we'll give breakfast to the child. And then we'll start doing all the assessments. So the family actually comes for at least 5 hours and is with us in the lab, so that a lot of the assessments are done. So it's a very time intensive kind of job. But we've done all this. We've also looked at grandparents. We've looked at fathers. We've looked at gender discrimination. So many such factors, which are also social factors, which may also determine what happens to these kids over time. This is just to give you when the babies were 6 months old. So we do these, we have a standard set of mother-infant interaction. We have a standard, we tell the mother, it's a 14-minute video that we do. So for 7 minutes, the child plays with its favorite toy. So the mother brings the favorite toy from home. And then we have a standard set of toys. So the mother interacts with the baby with these toys, and we assess for what we said, maternal sensitivity. We have mothers' mental health parameters already. We are looking at mothers' depression, anxiety, stress, and we are looking, then we video this whole 14-minute video, and we sit and code second by second. The video is 14 minutes. The coding takes 2 days for each video. And we have 600 such videos at 6 months, 5 years, 7 years. But this gives us an idea about what is the sensitivity like. How is the mother responding? And we can see many times if a mother is very withdrawn, she will actually not play with the baby. She will be in her own world. Or she'll play things that she wants and not bother about the baby. Or there are some mothers who, like these mothers, who seem to be so engaging. And all these mothers, they'll come to a lab, and we have a lab fitted with videos, cameras, and we take everything and code everything and keep it in very, very large servers so that it's available for people as a database. And it's an open database, which a lot of people now are using to, look at maternal sensitivity. This is the saliva sample collection. Like I told you, this little kid, they come to a lab and then we take the saliva. These are some of the tests that we do, cognitive tests at every stage, 2 years, 5 years, 7 years, very detailed cognitive assessments. That last one is a very interesting study we do to look at how much the children are able to regulate themselves. So basically, this is a closed room. There are closed circuit cameras there. We have told the child that there are 2 bowls. One has 2 sweets in it. One has 5, 10 sweets in it. You have to wait till we ring the bell. You should not eat any of those sweets. If you eat, then you'll get only 2 sweets. But if you wait, you'll get the 10 sweets. So it basically looks at how the child is able to manage frustration and manage their own emotions. And the videos are very interesting because some children within 1 minute, 1 second, they'll eat everything. Or they'll start ringing the bell. And some are so patient, they will actually sit and, wait. But all these things tell us about the child's temperament. How much is the frustration tolerance? Is this kid able to manage its emotions better? We have another task where the researcher will feign that they've got pricked when they're opening a file, that they'll say, oh my God. And then we look at empathy to see how this child is responding to this prick. So some people will not do anything. Some people will say, ठीक से करना था ना, तुम्हारी गलती है. Some people will say, क्या हुआ, मैं पानी ला दूं, मैं लगा दूं. So we then code that empathy. So all this data, which is cognitive, which is behavioral, which is biological, is actually coded to make sense of what is happening in this child's life from the time she was in the womb to her life 10 years later. We are also looking at alternate caregivers. So if you see there's a grandmother there. So we do these tasks with if there is a grandmother or a father who's one major caretaker, we actually do these same videos with them also to see how much is the grandmother looking after. Is she sensitive? So even if a mother is depressed, if there is a sensitive grandmother, then the child may be protected. So all of these things are important in a child's environment or the father. So, and this is one of my young colleagues whose PhD is in this whole area of what we call alternate caregivers and what impact that has. This was the study that we published, which basically showed that anxiety and depressive symptoms predict low birth weight, but differentially in male and female infants. Female infants had more low birth weight than male infants. So there seems to be, again, some difference in the sex also. Okay, I'm going to show my final slides. This is my PhD student who just got a PhD, Afreen, who basically looked at domestic violence during pregnancy and childbirth. And she basically traced the trajectories of domestic violence from pregnancy till the mother was 10 years old. What happened? Was it low? Was it high at all points? Was it more in pregnancy than came down? Was it less in pregnancy and then came up? And then try to understand how each of these has impacted the child's mental health and the child's immune status. So we also looked at how violence predicted the child's cytokines in the child's saliva. What difference did it make? Because we know that watching violence can be equally stressful. It's not just that you have to face violence, but a child watching conflict between parents can actually impact the baby. And we have actually found that a child as less as 6 months old, if there is violence in the family, especially psychological violence, fighting in the parents, it seems to be impacting the baby's self-soothing behavior. So people think ये तो baby है, उसको क्या समझ आएगा? The baby will not understand. But the baby understands body language, the baby understands noise. So conflict in the family affects a baby as young as 6 months. And all this data we are getting. And all this has important implications for policy, for parenting training, for educating people, that how environment in a small baby's life can make a lot of difference. So if you see these rates so high, and this is in pregnancy in the postpartum period, psychological violence as high as 42%, physical violence as high as 16%. That's a lot. Imagine 16 out of 100 women are actually facing physical violence, and what impact that is happening at a very vulnerable time, both for the mother and the baby. This is my collaborators from University of Liverpool, the two PhDs, and what they found was that any domestic violence was significantly associated with child emotional problems at age 4 years and at age 2 years. And this seemed to be mediated by depression. So if a mother is facing domestic violence, she, because she is depressed, that is actually impacting and leading to behavior problems in the children, emotional problems and both behavior problems. Again, showing how maternal stress can actually directly impact either directly or through other pathways. Like I said, this is Kavya. She's just submitting her PhD. She's a biologist, and she looked at, she handled all the methylation data and all the cytokines and looked at any kind of violence in pregnancy and the various cytokines which were there. Some mixed findings here, not great findings, but I think we will get more in the methylation data. So this is what she then looked at. She looked at prenatal stress and DNA methylation. And basically, it was called epigenetic memory. That is the intergenerational effect of stress on the methylation and how it impacts later behavior problems. So we had 157 paired mother child samples with the second trimester maternal blood sample. And we did, like I mentioned, offspring saliva at 1, 2, and 5 years. This is just the workflow. And like I said, we basically were very interested in the stress, the NRB3C1 gene. And if you look at this data, which has just come out very recently, that there was association between maternal IL-6 and DNA methylation at 1 year. So maternal inflammation in second trimester had an impact on DNA methylation at 1 year. At 2 years, again, many genes have been looked at. Again, if you look at the NR3C1, CPG1, very high significance of these. So it clearly that there is either inflammation in the mother, and this is maternal depression and child methylation at 5 years. Again, if you look at the ones on top, it's quite significant. So basically trying to say that maternal depression in the second trimester of pregnancy seems to have an impact on DNA methylation even at 5 years. Okay, so this is the kind of data that we are generating. Like I said, it's complex data. This is very direct relationship. We have to handle confounders also here, which we are currently doing. So this is the format that I gave you earlier, and I hope I've convinced you that it's very important not to just look at prenatal stress, but also postnatal stress, how both of them can combine, cause epigenetic changes, changes in the HPA axis and the autonomic nervous system, neurodevelopmental problem, and other problems like ADHD, depression, anxiety. In fact, they have shown now that many studies have now shown that mothers with depression in pregnancy or postpartum, when the children are in adolescence, they are developing depression. So it seems to be quite linked to each other. And this is not because of environmental factors. Independent, if you control for all environmental factors, still the relationship remains. So I think if we want to advance research in the field, the important thing is to have a well-defined cohort with a very good interdisciplinary team. This cannot be done by clinicians alone. This cannot be done by basic scientists alone. This cannot be done by statisticians or people who have machine learning knowledge. It has to, everybody has to come together to do this kind of, if we want to understand these complexities, we need to understand different pathways, psychological, physical, and social. One of the things that we are now trying out in another group is to look at omega-3 fatty acids as neuroprotection. So this might be something which many of you might be interested in. There is some evidence to say that omega-3 fatty acids actually help the fetal brain, even if there has been some insult. So trying to see whether nutrition and omega-3 fatty acids, because we know omega-3 fatty acids have a role to play in depression. So, trying to see whether this is something that might be helpful. And I think longitudinal research, like I said, where requires advanced methods, but we have shown that it is possible and it can be done. So I will end with that. If you want to see how research informs policy, I think the important thing to remember is that if early adversity becomes biology, okay, so we are saying early psychological, social adversity is becoming biology. It is not just the mother is tense, the mother is stressed, she's facing problem. It is becoming biology. It is changing the fetal brain. It is causing changes in methylation. So then prevention, care, and policy must begin much earlier than what we once imagined. Okay, I end there. And these are, if people who are interested in looking at some of the resources, you can use this QR code to get access to the papers that we have written, to our database, to anything else. And if anybody wants to collaborate with this group, we are very open to collaboration, and this is my email. So I thank you very much for your patient listening, and I'm happy to take question and answers. I'll keep this with me.
Yeah, so yes. Mike, Mike, Mike.
Yeah, you're very right. So one of the things that we have done is that in addition to domestic violence, we also do a general measure of stress, like how stressful are you feeling about overall stress. It may be at workplace, it may be at home, it may be traffic, it may be whatever. And we've actually found that more than even depression and anxiety, stress seems to be predicting many of these. So we are coming up with a composite measurement of stress. The composite measurement of stress is anxiety, depression, workplace related stress, home related stress, and other bullying, violence behavior. Abroad in the West, they have also looked at racial discrimination and some other kinds of stress also. So I think very context specific, but you're very right. In fact, now we are actually developing programs for workplace maternal mental health, because that is a time when the woman is pregnant, she has to come in, compete with her male colleagues, then immediately after the childbirth she has to again come back, and she's leaving the baby at home. It's a very, very difficult place to be in for mothers, and trying to develop a program which can help mothers. So I'm working with workplace maternal mental health also. So very valid point.
Yeah, madam, very nice as well. Yeah, I was wondering, did you, apply any of these studies to orphanage children?
Very, very good question. In fact, a lot of the science originally came from orphanage children who are orphans. So there was a big study in Romania, which was actually brought out this science, where they found that in Romanian orphanages, children were just left, and these children were taken up later for adoption, and they were completely non-reactive. They were very withdrawn or had very, very high levels of problems. Now, what happens now is places like Kara, which are the adoption agency, as you know, the central adoption agency in India. Now we are training all the staff in these orphanages and adoption homes to make sure that they give, because like I showed you, sometimes if the mother is not there, if there is another sensitive caregiver, then you can ameliorate many of these problems. So these babies have had double problems. One is they have been removed from their attachment figure. Attachment is something that all babies need to feel there is one safe person who is available whatever happens. If that doesn't happen, this baby is not able to trust the world after that, because the world is an unsafe space. So we are trying to ensure that these staff in orphanages are actually being trained to look after the babies in a way that the children don't get too affected. But there are quite a lot of studies which have indicated the children who have been abandoned in orphanages have a lot of major problems.
Just a follow up.
The other issue is that when we were doing this study, we had quite a few families. I mean, not many, but 4 or 5 families where the mother had abandoned the child, or both parents had left the child with the grandmother and gone. We have had to keep at least 2 children in child protection because we found that these children were completely being neglected. So we are following up those children also to see what is happening to those children, because they had complete neglect. When they after they were born, both parents had alcohol problems. They just left the baby with the grandmother and went away. And when we visited the child to do assessments, we found that the child was in child welfare, and we continue to see the children through child welfare. So these are very challenging situations which even we did not think will happen when we do a cohort like this.
Thank you.
Thank you.
Hello, ma'am. Fantastic talk. Just wondering, since you have the resources, beta HSD, which will determine the outcome, like how much cortisol would be available or go into the maternal fetal brain. Have you looked up the gain of function or loss of function mutation in Indian cohort? Like, what you have the resources, you can do that.
We can look at it, but it happens in the placenta. So we have not collected placenta.
Okay.
But there is another study, new cohort which has started, which is also collecting placenta. So in that group, we can actually look at it, because this happens in the placenta.
Play a very determinant role. If there is a loss of function or gain of function, how much cortisol is going to the
very,
fetus?
very true. Very true. In fact, there is a particular sweet,
right,
which when people eat, it inhibits the beta HSD2. And people found that women who were taking this sweet, it's like a gum which a lot of people eat in America and Australia and all. When they were eating the gum, they were finding that the children were developing neurodevelopmental problems. Then they went back and found that this particular gum was actually an inhibitor of beta HSD. So you're very right in saying that, but we don't know whether it is the absolute value of beta HSD or it is the downstream effect, whether it causes some downregulation. That is, it's a little complex, but it's a good point. There's a question there. No, all these mothers were pregnant when we recruited them. So they were they were already in the first or second trimester of pregnancy. Many of them have had babies after that. They've had second pregnancies. Your question is whether depression caused a problem in conception. That was not our primary sort of aims, because we were looking at the index child and the mother's downstream effects. But I think that's a very valid point, that mental health problems can actually impact fertility in many ways also, including causing some amount of suppression of the anti-Mullerian hormone, particularly in some women who have other risk factors. So it's a very valid point. Thank you.
Thank you so much, Dr. Chandra, for that really fascinating talk and with so many open questions. Of course, we could go on and on and on. There is maybe one more question at the back. I'll keep it short. When people study stress biology, they differentiate between acute stress and chronic stress. And chronic stress is typically considered to be much more heinous and having much more negative effect on immune system and so on and so forth.
Yes.
In the context of pregnancy, also, I assume there is a difference.
Yes.
Acute stress has less. But have you looked at this question, and how do you define chronic stress for a 9-month period of time and beyond? So have you developed metrics for that?
Yeah, no, very valid point. So what we do is we ask them questions from the last time we saw you, how will you rate yourself in these parameters? So the way we do it is, so we do the cross-sectional, but we also ask them from the last time we saw you, how much time you have been feeling like this. So they will give us a measure of that. And you're very right, the impact of acute stress is different from the impact of chronic stress. The impact of acute stress is like in disaster,
Right.
the sudden stress. That probably has a different downstream effect. compared to chronic stress, which is probably more immune mediated and things like that. Whereas acute stress is more autonomic, catecholamines, with that freeze, flight, fight, flight kind of a thing. So the impact is going to be very different between the two. So not to say that one stress is less or more, but I think the downstream effect is going to be slightly different in both, is my understanding from this data.
Right.
Yeah.
And the other question is that you could say that stress or chronic stress leads to increases in blood pressure or increases gestational diabetes. So it could be these other things which mediate the birth weight effects. How do you
So what we did was in
separate
that paper I showed you, we actually controlled for everything.
Okay.
We controlled for anemia, we controlled for any high risk conditions. We had data on their blood pressure, hypertension, any eclampsia, preeclampsia, everything. So we controlled for body weight also, to try and see that the low birth weight was not because of anything else. So we did a fairly good, looked at all possible confounders. It was a big list of confounders. But even after controlling for all that, we found that in girl children, the impact of anxiety and depression independently predicted low birth weight. But it's a very, very important scientific question, because there are so many things which are happening, and maybe there may be still something that we missed. It is possible, but we tried to do control for as much as possible.
Thank you.
Can't hear you.
Family.
Yeah, thank you.
Field in the maternal stress separation, and I just wanted to any methylation can happen. My question is, like, it be reversed in this, but
Great question. I don't think it is reversible, but maybe preventable. So I think, like I said, some neuroprotection or trying to do things in that period. If you feel that a mother is very stressed, or a mother is depressed, or the mother is facing a lot of challenges, to be able to provide support systems, like, some policies like good creches in workplace, support systems of being available, all of that can actually prevent some downstream effects from happening. But once the methylation happens, to reverse it may be very, very difficult. But at the same time, human resilience is very, very great. So many things we can do to protect the child from developing more problems also. So we know this child is vulnerable. There can be a lot that can be done to prevent this child from developing more problems, even though the methylation may not be reversed.
So I know that this is a very wonderful talk. We can connect later, please. I hope she has answered the question on how mothers' mental health can affect physiology and mental health of the child. This reminds me of the baby monkey Punch, who was abandoned by her mother just after the birth. So this research topic is still valid in the animal kingdom as well. And with this, I would like to invite Director Madam to present her with memento and gift. As we move towards the conclusion of this session, I invite Dr. Vivek Bhosle, Chairperson of Translational Research Series, to deliver vote of thanks.
So, thank you, Vinita. So it is my great honor to give votes of thanks for this excellent lecture. I on behalf of CSIR-CDRI, express our deep gratitude to Dr. Prabha Chandra for delivering such immense lecture. And I also know that she's doing a study of a 10 years duration. That is a really Herculean task. Even 6 months study or 1 year study, it is difficult to manage. Many patients go for transfer or go to they change their houses, etc. So difficult to keep that. But even for 10 years, the follow up is going on. That's a great study. And also you great thanks to our director to arranging such excellent series of translation series for this lecture. I also thanks our organizing team, Dr. Kumar Vilu, Dr. Ravi Bhatta, Dr. Vinita Rai for excellent management of this study series. And I also thank Dr. Shubha Shukla, who is a chairperson of this Women's Day celebration for this, and although a team of Women's Day committee that contributed immensely for this lecture. I also thankful the PME division, particularly Dr. Ravi Londe, Kazim, etc., for organizing these mementos, etc., and also thank for canteen committees and auditorium people, Sumit, etc., for the thing. So I once again grateful to Dr. Prabha Chandra for taking the time to visit CSIR-CDRI and sharing such insightful lecture with us. And we hope this interaction will be the beginning of a meaningful scientific association between NIMHANS and CDSI. So thank you all for your presence and participation. Thank you.